All right, well, let's go ahead and get started. So thank you to all of you for coming to our colloquium. It's just great to have you here. And I have the pleasure of introducing a special guest today, Dr. Matthew Modis, who is, I know sometimes these things are out of date online, but are you still an assistant professor of medicine
Yes.
at Cedars-Sinai?
Yep.
Um, and he is engaged in research that is certainly dear to our hearts on the role of spiritual care and chaplains in the ICU setting. And so he is here to talk about his research and have a conversation with us about what he's been up to. And really excited to have him. And so take it away, Matthew.
Okay. Let me share my screen. Can you see that? How about now?
There we go. Yeah.
Okay. Great. So thanks for that introduction. And, I'm really honored and excited to be chatting with you all today. Huge thanks to Doctors Torkey and Hickman. I've admired your work for a long time. And it's really kind of you to invite me to share a little bit about what we've been up to. I have no conflicts of interest. The work I'm going to be talking about today was funded by the National Palliative Care Research Center. Here's the agenda, just like a little bit about me and my team, the clinical problem, the intervention, which for us is called the Family Perspectives Program. We did a single-arm feasibility study. We're now in the midst of a pilot randomized trial. Briefly touch on next steps, and then hoping to leave ample time for questions and feedback. And really just a discussion. I mean, you all have a lot of expertise. I would love to learn from you. And as you'll see during the talk, we're still tweaking things about this intervention we developed and the implementation, and we're trying to improve it more. So if you all have ideas about ways we might improve things, please share them. I would really love to hear them. Firstly, briefly about me, I'm a pulmonary and critical care medicine physician at Cedars-Sinai Medical Center in Los Angeles. Clinically, I do most of my work in the ICU, which is also where my research interest lies. And my goal is to develop innovations that enhance the psychological well-being of adults with critical illness and their families. And my short-term goal is to develop an intervention to enhance emotional support for the families, which really builds on my experiences as a critical care physician, and that's what I'm going to talk about today. Prior to joining Cedars-Sinai, I did a fellowship in pulmonary critical care medicine at University of Washington in Seattle, and was kind enough to be supported on palliative care T32 at the Cambia Palliative Care Center of Excellence for several years. And I do just want to acknowledge and thank the many people who've been instrumental in supporting me over the years, and just highlighting my primary mentors, Aaron Cross at University of Washington and Terrell Nichols at Cedars-Sinai. So over 5 million Americans receive care in an intensive care unit each year, including 1 in 3 older adults in their last month of life. And families of these patients often experience distressing emotions, which can negatively impact their psychological health and ability to make decisions for their critically ill loved ones. Recognizing this, guidelines, critical care guidelines, recommend that ICU teams provide emotional support to families, not only medical information like prognosis and treatment options. And emotional support means responding to a person's emotions with empathy, caring, and non-abandonment. When families receive emotional support from ICU clinicians, they report less psychological distress, greater satisfaction with communication and care, greater trust in clinicians, and higher quality surrogate decision-making. Yet, despite the importance of emotional support, there's a variety of studies that have shown that ICU clinicians provide infrequent, poor, and inequitable emotional support to families. So we sought to develop an intervention to enhance the frequency and the quality of emotional support for families of critically ill patients. And this is a hypothesized pathway by which our intervention would work. We call the intervention the Family Perspectives Program, or FPP. And the crux of all this is really the behavioral risk factor. We believe there's good evidence that family emotional distress, unmet needs is a risk factor and target to improve both family-centered outcomes and also patient-centered outcomes via surrogate decision-making. And this impact on patients is rooted in cognitive emotional frameworks of decision-making, with the idea being that distressing emotions that are unaddressed dominate and disrupt the ability to cognitively process information and deliberate among options. So to develop the intervention, we've been following the ORBIT model for behavioral intervention development. The NIH stage model is an alternative that a lot of folks like too, and I think there's a fair amount of overlap between them. And right now, as you'll see in a minute, we're at the preliminary testing phase. And our goals at this point are to see if we can implement the intervention with fidelity, assess feasibility and acceptability from all participant groups, and examine participant experience with the intervention. So this is what I'm going to focus on today. My hopes are also, I'm sharing my hopes of where future funding might fit in, and I have an application out for a K-23 right now that would be sort of like a stage 2 NIH stage model, and then if I'm lucky enough, the R01 would be looking at more like a phase 3 efficacy trial. So this is the vision. But first, let me talk about what the intervention is and how we designed it. So when it came to designing the intervention, we asked ourselves, how do we increase the frequency and quality of emotional support for families? And how do we do it in a way that does not unintentionally worsen disparities in emotional support and ideally mitigates them? And the first thing we did is we sort of backed up, and there's a lot of smart people that have looked at different strategies to change the behavior of healthcare providers or the use of services by healthcare recipients. The Cochrane Effective Practice Organization of Care, or EPOC, is a group that characterized and defined a taxonomy of 11 different improvement strategies. A lot of this comes from the QI literature. And the group gave sort of general advice that a multi-component intervention is usually more effective than an intervention that uses only a single strategy, and that the more effective interventions select strategies that are matched to address barriers. And our intervention, you'll see, sort of maps to these 4 strategies that systematic reviews rate as some of the most effective of the EPOC strategies. So these are team changes, changing the structure of the healthcare team, facilitated relay of clinical information to clinicians, which is clinical information collected from families and then transmitted to clinicians, coaching, guidance provided to clinicians in their own setting by a trained person, and clinician reminders, which are prompts to perform an action during interactions with families. And we think these help address the barriers that clinicians face when it comes to providing empathy and compassionate care. And that's lack of time, a poor understanding often of family perspectives, high pressure situations, high cognitive loads. These are well-meaning clinicians. It's just there's all these sort of barriers about the ICU environment that make it difficult. So first we thought, let's change the team a little and bring in some experts who have the training, the skills, and the time to provide emotional support. And here are some of those experts at Cedars-Sinai. They are board-certified hospital chaplains. And I believe, chaplains are underutilized in ICUs. They're uniquely positioned to provide emotional support to families with or without often overlapping spiritual support. I don't have to tell this audience, but they're trained to take a culturally sensitive, supportive, a non-judgmental approach. They're trained to talk with individuals of all faiths, including no faith, which is like a growing group in the United States. And chaplains really play the key role in our intervention, in that families are paired with a chaplain who meets with them early in the ICU course, follows up with them over the ICU course. And just to mention it, currently in our ICU, our medical ICU, there's no chaplain assigned to the unit. Though there has been in the past, our spiritual care department has experimented with different models of how chaplains operate in our hospital. My sense is that regardless of the model, I think they're still underutilized in the ICU, or at least misutilized in the ICU. So the chaplains play the key role of providing family support, which sort of complements, enhances the ICU teams. And we also thought, and I think families tell us, that they want emotional support from the ICU physicians and the medical team too. So we asked ourselves, well, how do you help a busy and often stressed, well-meaning ICU physician be more empathic? And we landed on perspective taking. Perspective taking is essential for empathic communication and care. It's actively adopting another person's thoughts, feelings, expectations. It's really about putting yourself in someone else's shoes. And there's good evidence from the psychology literature and some clinical studies as well that perspective taking increases empathy, it increases positive attitudes, and it decreases racial stereotyping and bias. Chaplains are already experts in perspective taking. But for those busy ICU physicians, we think you can prompt perspective taking. And the way that you do that is by asking people to slow down, read brief perspectives, like 5 to 10 minutes, of other people with explicit instructions to adopt those perspectives. And now the evidence demonstrates that perspective taking works best when the perspectives being considered are as individualized as possible. So how do we get individualized family perspectives to the ICU medical team? It comes back to the chaplains. In the process of providing emotional, spiritual support, chaplains learn a lot about what families are really thinking and feeling and experiencing. And so we ask them to summarize the family perspectives in a standardized way, and we assemble this into a structured report with added perspective-taking prompts that we then relay to the ICU medical team. And this is a kind of facilitated relay of clinical information and also clinician reminders. And then in addition, we ask the chaplains to make tailored suggestions on how to communicate and support the family. And we include those in the structured report. And we think of this as sort of like coaching or coaching adjacent. Now, sometimes when I tell people this, I hear worries that we're asking the chaplains to act as spies. And that's really not the case. Families are aware from the start that the chaplains communicate with the ICU medical team so that the medical team better understands their perspectives and experiences. It's about getting everyone on the same page. And we tell the families, and the chaplains tell them too, that anything they want to remain confidential between families and chaplains will not be communicated to the ICU medical team. And this aspect was particularly important to the chaplains who we engaged early in the design process. So we have reviewed the literature, we have drafted components of an intervention, that involves a lot of different people, and we needed to talk to those people and see what they thought. We wanted our intervention to be pragmatic and align with the workflow and be doable for hospital chaplains and ICU clinicians, the doctors, the nurses, the social workers, and of course the families. So, I started by meeting with the leaders of spiritual care at Cedars-Sinai, Rabbi Jason Weiner and Reverend Pamela Laser, and they both liked the idea of boosting chaplain involvement in ICUs, both with families and also with the medical team. And then I met with the director of the medical ICU, Dr. Isabel Pedraza, which, that's the unit I work in, which definitely helped. She was also supportive. And then we interviewed potential participants. We met with senior hospital chaplains, clinicians who worked in the medical ICU, families who had experienced a loved one in the ICU, and we showed them the candidate treatment components of the Family Perspectives program. We shared drafts of study materials. With the chaplains, we particularly focused on how to make this doable, given their other commitments. A lot of them see lots of other patients and families around the hospital. And based on these interviews, we made refinements to the intervention, the data collection method. Survey lengths were too long. One thing that came up over and over in all the groups we interviewed, including the chaplains themselves, was the concern that chaplains are misunderstood. And we've grappled with this and how to handle it. Sadly, like, the term chaplain is totally loaded, particularly in the ICU. Does this mean my loved one's dying? I'm not religious. I don't want to be proselytized. There's all these thoughts that come up. And so we chose that instead of trying to refute all those myths and educate distressed families while we're trying to recruit them for a study, we chose to call chaplains ICU support counselors in this study. It's actually a name suggested by a family member in one of these interviews. And our chaplains are comfortable with this. They wear badges that say ICU support counselor on them. At the same time, I do want to make it clear, we don't hide the fact that they're chaplains. If a family wants more information about the ICU support counselor's background, we say that they're chaplains, and then we try to educate and dispel any myths. Sometimes the chaplains tell the families in their meetings that they're chaplains and also, educate. But my belief is that this is about getting in the door. And I often think about religious, spiritual, and sort of emotional in this pyramid. I don't know if the pyramid is the right shape exactly, but the point is, I think chaplains have the training to help all these groups of people who are religious, people who are spiritual but not religious, people who have emotional distress but maybe not spiritual distress. I think chaplains have the training to help all these groups of people. And I think there's potentially massive misalignment between who the chaplains are seeing and who they can actually help. And so that's why we call them ICU support counselors. I've gotten feedback from some people who feel like we're being disingenuous. I totally respect that. I don't feel that way. I'd love to get people's thoughts on it at the end, but I just want to be transparent about what we're doing. So quickly back to the intervention. So the intervention operates over the course of the patient's ICU stay. Here's a cycle of it. The families meet with the chaplains early in the ICU course. The chaplains provide emotional support and also potentially spiritual support. We do try and match chaplains on patient and family demographics and religion as able. And then the chaplains then catalyze ICU clinician provision of emotional support by creating standardized reports. The chaplains, they do have a structured discussion guide that we use for meetings. And they also have a templated report to help standardize how they use their skills to summarize the family perspectives. And I'll show you an example of a report in a moment. And the study staff relays the report to the ICU medical team in ways designed to reach the entire interdisciplinary team and influence key opportunities to provide emotional support, in particular before family meetings. And then the clinician hopefully reviews the report, prompting them to perspective take, empowering them with tailored coaching in how they support and communicate with the family. And the cycle sort of continues that chaplains have follow-up meetings, something's changed about the family perspectives, which can often happen after a family meeting. The chaplains create a follow-up report, and then we disseminate those updates. So said another way, the intervention is basically early and regular chaplain meetings and structured communication between chaplains and the ICU medical team. That includes the family's perspectives, perspective-taking prompts, and the chaplain's suggestions. And at our institution, and I think at many others, though certainly not every, usual care consists of rare chaplain involvement with families in the ICU. When it does happen, it's usually late. It's often one time, and poor communication between chaplains and ICU clinicians. To back this up with some numbers at our institution, we surveyed the attendings and fellows who work in the medical ICU at Cedars-Sinai, and we found that only 26% felt they were usually or always aware that when a chaplain was involved. 0 usually or always speak to the chaplain. 20% usually or always often read chaplain notes. Only 8% usually or always found chaplain notes helpful. 0 felt they had a very good or excellent understanding of what chaplains do. And yet, 80% said they were very much so, or exceptionally comfortable receiving suggestions from a chaplain about how to proceed with communication. So first we did a single-arm feasibility study where we planned to enroll up to 10 families and put them all through the intervention. Before we enrolled any families, we first enrolled all the providers, and the provider enrollment sort of covered the single-arm feasibility study and then also the subsequent pilot randomized trial that we're doing now. We enrolled 41 out of 44 ICU doctors, 93% that we approached, and 37 completed enrollment questionnaires. Here's their characteristics. They were have a median age of 34. It was about 50-50 male, female. 46% were Asian, and 41% identified as white. 10% identified as Hispanic, and it was about a 50-50 split between fellows and attendings. 5 of the Cedars-Sinai chaplains agreed to participate as ICU support counselors. And they all completed enrollment questionnaires. And here are their characteristics. Their median age is 52, split between female and male, a diverse group from a racial standpoint, a diverse group from their own religious backgrounds. They had a median of 8 years in practice, and they were all BCC board certified. We also enrolled 5 social workers and 18 nurses in hopes that they would attend the physician-led family meetings and complete questionnaires after those meetings as well. So these are our goals for the single-arm feasibility study. Could we implement the program with fidelity? Is it acceptable and feasible to participants? What's the participants' experience? This is the flow through the single-arm feasibility study. We enrolled eligible patients and their primary surrogate decision maker on roughly ICU day 2 to 4. They all received the program. We asked them to complete post-meeting questionnaires after every family meeting they had with the ICU medical team, and then one at 1 month and 6 months. Chaplains completed surveys after meetings that they had with the family, and then any ICU clinician, physician, or social worker completed a survey after any physician-led family meetings that they attended. Here's the kinds of things we were asking participants, though we're really only looking at the fidelity, acceptability, and feasibility measures in these preliminary studies. But we're also sort of informally learning how some of these other measures are performing. We're using a couple novel measures that haven't been used in the ICU because a lot of studies have had challenges with moving measures that may not be the most responsive or the best for this population. So we're trying some new things, but we're really looking at, like I said, fidelity, acceptability, and feasibility measures. And our fidelity measures are that the chaplain met with the family, they provided emotional support, they created the report content, they documented the content in each structured area of the report, the study staff then delivered the report to the clinicians, and the clinicians reviewed the report. For acceptability, we use the validated 4-item acceptability of intervention measure. For feasibility, we use the validated 4-item feasibility of intervention measure. This is the patient inclusion and exclusion criteria. We've actually updated it since then, but this is what it was at the time. The inclusion was individuals with acute respiratory failure defined as a need for invasive mechanical ventilation. They had to be on the ventilator within, first we did 24 hours of ICU admission, then we decided to loosen it to 48 hours. And they were expected to need the ventilator for at least 72 hours per the attending or fellow ICU doctor. If they were excluded, if they had any of the following, they're expected to die within 24 hours, with a clear preference for comfort care, decisional capacity, imminent organ transplant, they were unrepresented, chronically dependent on a ventilator, or if they had a pre-existing relationship with a chaplain who chose not to participate as an ICU support counselor. We didn't want to, get in the way of those existing relationships. The family criteria was simply identifying the person who felt most responsible for decision making for the patient. And if families made decisions jointly, then any one of them could enroll. Multiple family members could meet with the ICU support counselor in the visit. We just had one enrolled who agreed to do the questionnaires. So here's the rundown. There were 49 eligible. We approached 35. We enrolled 9, which is about a quarter of the number we approached. All 9 met with a chaplain. And jumping to the right side, the initial chaplain meetings occurred a meeting of 4.1 days after ICU admission. They lasted a meeting of 55 minutes. Emotional support was provided in all 9. There's an optional part of audio recording in our study, and we were able to audio record 5 of the 9 visits. Jumping back to the left, all 9, there was a report created. 7 of the families had a physician-led family meeting, and the report was reviewed for all 7 of those by the ICU physicians and other providers attending the meeting. Jumping back to the right, the initial family meetings were a meeting of 4.8 days after the ICU admission. They lasted a meeting of 40 minutes. The majority of families reported expressing emotion, particularly negative emotion, during the meeting, suggesting there were opportunities for clinicians to provide emotional support. And 3 of the 7 were audio recorded. Jumping back, 6 of the 7 families completed the post-meeting survey. 3 of the families had follow-up meetings with the chaplain. A report was created for all 3. 2 of those ended up having a subsequent physician-led family meeting and filled out their post-meeting survey. And then at the 1-month mark, we had 5 complete survey, and at the 6-month mark, we had 3. And we're actually moving away from, I think, the 6-month survey in future stuff. But from this, we felt like we were able to implement the program with pretty good fidelity. Here's the patient and family characteristics. The median age was 79. The minority were female. There were 2 Asian, 1 Black, 2 Hispanic, and about half were non-Hispanic white. And I think it's probably a good opportunity to dispel some myths about Cedars-Sinai. Sometimes people think it's like a hospital for the stars, and that's like a very small sliver. Honestly, it's actually pretty diverse. It really reflects the population of LA County, which is very diverse, and we've had that in this and in the pilot randomized trial. And personally, I think this is awesome. I think it's a very cool opportunity to look at differential experience, and this is something we're going to be doing over the coming year. The patients were pretty sick. The Apache 2 median was 31. For reference, score over 20 has about a predicted 40% in-hospital mortality. Family members were a median age of 54. The majority were female. And diversity in race and ethnicity. Diversity in relation to the patient, about half lived with the patient. There was some diversity in their religion. And then we asked them, how important is your faith or spirituality in your daily life on a scale of 0, not at all important, to 100, extremely important. And the median, was 90. So, family members were actually quite, spirituality was quite important to them. So here's a list of the interventions that the chaplains performed during the 12 meetings. There were 9 initial and 3 follow-up. And we created the list of potential interventions from a combination of a Cedars-Sinai spiritual care department list of interventions, and then also the chaplaincy taxonomy of interventions in the ICU, which is a paper that's been published. The Cedars-Sinai list had 40 interventions, and we asked our hospital chaplains to give us the most common 10 to 20 in the ICU. The chaplain taxonomy list has 59 interventions, and a lot of them were overlapping with the Cedars-Sinai one, but we made sure that the top 10 most common interventions in the ICU from the taxonomy were all on our list for this study. So we ended up with 28 potential interventions, and we asked the chaplains to mark all that they did after each meeting with the family. And in these 12 meetings, you'll notice that chaplains are providing a lot of emotional support and also a fair amount of spiritual support. Even though we frame this as a emotional support intervention to the families, which speaks to, I think, the often overlapping nature of emotional and spiritual distress, and why I think chaplains are ideally positioned to support families. As I mentioned, the reports were created after every chaplain meeting. I want to show you an example of a real report in a second, de-identified, of course, from the feasibility study. I'm going to blow it up on the next few slides and we can read it together. And the way we're currently doing this, though I'm open to other ideas, is that when a chaplain walks out of their meeting, we have a study coordinator hand them a laptop with a survey in red cap, and the survey has questions that prompt free text responses in the different sections of the report. So for example, one of the sections is describe family feelings. And the prompt to the chaplains is listed on the bottom here. How do they feel about this? What worries them about this? What frustrates them about this? What helps them understand what is going on right now? Are they struggling with any decisions right now? What does it mean for them to go through this? What are they hoping for? Those are the kinds of things we're hoping the chaplains put in this section. There's some variability in how long it takes the chaplains to write the content of the report. They've gotten faster over time, but it does take time. I think you'll see that once the report comes, once we show the report. And then once the red cap survey is done, the study staff quickly assembles the content into the format of the report, which is a one page. So let's take a closer look. So I'm just going to read it. So this was, there's a section at the top, the name and the date of the ICU support counselor met with the family who was at the meeting. And then there's a section on the patient. In this case, it was, patient is a biracial person who grew up in Harlem, New York City. She's intelligent and strong-willed. She's from a race and culture that is often disregarded, undervalued, and marginalized. She and her sister raised the interviewee. She is educated and was a professional social worker. She is described as loving and giving. And there's a section on the surrogate decision maker in the family. The family is multicultural and most members are biracial. The interviewer is a criminal attorney and met his wife in law school. All family mentioned are professional, doctors, lawyer, etc., and all discussed have advanced degrees. The patient's generation rose up from poverty utilizing hard work, diligence, and education. Family is small but highly knit and supportive of each other. The patient's nephew is extremely close to her and sees her as a second mother. Family gets through difficult times by supporting each other. Family members have had bad experiences with organized religion and now practice personal spirituality. Then there's the next part of the report is this prompt of like, take the perspective of the family. Think about what it feels like to be in their shoes. And then there's the thoughts on the ICU situation. Patient's nephew has experienced an ICU and death experience with his own mother, who died about 10 years ago. The patient has been ill before, but not to this degree. The patient's nephew is concerned about the patient's recovery, but more importantly for her quality of life. The patient would rather die than live with a low quality of life. Feelings on the ICU situation. Patient's nephew expressed complete confidence in the medical staff, but feels excluded. Patient's nephew is focused on her healing, but struggles with the daily decisions concerning the patient's healthcare. He's not resentful, but feels left out of the information flow and decision-making process. He would like more information regarding treatment options. Patient's nephew would like to make treatment decisions with a better contextual understanding of the patient's quality of life potential. Patient's nephew wants a better understanding of treatment options and recovery potential. He feels that asking questions will interfere with the flow of treatment. Estimate of patient's feelings. The patient is trusting of the medical profession and care, but does not want to live with a low quality of life. Expectations of ICU situation. Patient's nephew is in the moment and feels that a higher power is in control. He is aware of the worst case scenario for his aunt. Past ICU experience. Patient's nephew felt ignored by the medical staff during his mother's decline and death, and feels the same with the current experience. He expects physician visit to be short and impersonal, but he prefers empathetic conversations. Expectations of family meeting. Family members fully trust the medical staff. They would like to be better informed, more autonomous in decision-making, and would like to be seen as a resource to the medical staff. Challenges facing. The patient's nephew is the primary contact and decision maker. The patient finds comfort in the fact that he lives 10 minutes from the hospital. It's important to him to be present and informed. Interactions with hospital staff. Overall, the patient's nephew is happy with staff interaction. He feels the patient is well taken care of and is happy with nurse interaction. He values doctoral competence but would like more sensitivity. Patient's nephew was disturbed by a physician's verbally and emotionally abusive chastisement of a nurse over an issue that seemed trivial. Patient's nephew was offended by the way the nurse was treated and that he was ignored. Support needs. The family members would like to be informed and would like to feel that asking questions will not interfere with the patient's treatment. Family would like the patient's desire for a high quality of life to be considered. Family wants to be seen as a resource, not a distraction. Then you'll see we ask the person reading the report to circle above what they read was most helpful and briefly why was it helpful. Then we have the ICU support counselor include some suggestions for the family meeting to move forward with communication, provide empathy and support. And so for the first one, to move forward with communication, the family does not want to feel rushed. They want to know their opinion matters and that they are a resource and actor in the treatment and decision-making process. They will need space and time to think, process the information, and ask further questions. Suggestions to provide empathy and support. Start by affirming the medical staff is here to support the family as well. Also affirm to the family their importance and this process, and that they are a resource. Attentive listening and follow-up questions. What are the patient's treatment and quality of life expectations? Do you understand? Do you have any other questions? How can we help support you? Please feel comfortable asking questions. Your understanding and input is important to us in your loved one's treatment. We see you as a resource. Help families share their perspectives. Empathy through eye contact should be communicated. Encourage the family to talk, listen to and identify the family's specific concerns. They need to know their opinion matters. And then at the end, we just have some general sort of examples of ways to express empathy if a family is expressing emotion, which comes from like the nurse mnemonic and I wish statements. So the report's hand-delivered by study coordinators to the physician and any other providers attending the family meeting, like the social worker or the nurse. It takes about 5 to 10 minutes for them to review. So like I mentioned, we asked clinicians to circle what you read above was most helpful to you and briefly why was it helpful. And we asked the clinicians to interact with the reports for a few reasons. And we like to use paper reports for this, to allow this. First, circling and writing requires them to more actively engage with the reports, which is hopefully pushing them to put themselves in the family's shoes a little more and really try to perspective take. Second, we want these reports to be helpful and valued, and so this helps us learn what clinicians seem to value in the moment about the reports. And we're planning to start using these to help chaplains see what kinds of information is being valued and try to improve the quality of the reports themselves. So for the circled sections, 7 of the 8 reports that were reviewed had circles on them. And these were the sections that were most commonly circled. Pretty much every section was circled at least one time. It seems like past ICU experiences is particularly important to the ICU physicians to learn about. 6 of the 8 reports had an answer to the why was it helpful question. And here were some of their responses. For the sake of time, I think I'm gonna not read them. So what was circled in this example report? So in this, ICU doctor circled that the patient would rather die than live a low quality of life, and that the patient's nephew feels excluded. And the anecdote about this is that the physician leading the meeting made a comment, I don't know why he made this comment, to the study coordinator before he was given the report to review. And the comment was something like, oh, this is going to be a quick meeting, like 10 minutes. And then the coordinator hands the physician the report. And as she was telling me the story, she's like, as she's watching his face and he's reading it, she can kind of see his like, oh, this report is about how the family feels excluded and that they feel like the doctors are rushed and they want the doctors to slow down and take a little more time and create an emotional connection. And the physician then, who was like, oh, it's going to be 10 minutes, he then went in and proceeded to have actually an hour meeting with the family. And when the family completed their post-meeting questionnaire, they rated the physician as excellent in several domains of the clinician empathy scale that we're using, including making you feel at ease, really listening, being caring and compassionate. So it's an N of 1, but I would like to think that the report made a difference, in this case. Here's an example of one where the physician really engaged with the report by underlining, but didn't actually answer the why was it helpful question. So we're also allowing physicians to verbally summarize why it was helpful to the study coordinator. And I don't think I have time to read the specifics here. So in terms of results, chaplains felt that in 11 out of the 12 meetings, the family opened up and really offered deep insights into their perspectives. The 6 families who completed the post-meeting questionnaires all completely agreed that they felt supported by the ICU support counselor. They would recommend the ICU support counselor to other families and patients. And the ICU doctors rated 4 of the 6 initial reports as quite a bit or extremely helpful. One was not asked in air, though I interviewed him later, and he seemed to feel like it was a good report. One of the reports that was not rated as quite a bit or extremely helpful was one of the one meeting where the chaplain felt the family didn't open up and offer deep insights. So, which kind of makes sense. One family member just hand wrote on their post-meeting survey, "The counselor was amazing, provided incredible emotional support. I felt relieved for the remainder of the day." And all the participant groups felt that the intervention was acceptable and feasible. The AIM and FIM are on a 5-point Likert scale, with greater than 4 agree that the intervention was acceptable and agree that the intervention was feasible. And you can see the median scores were pretty good. And everyone agreed or completely agreed that they would participate again. You know, these are small numbers, but you know, at least it encouraged us to press on. We also looked into survey burden, and survey burden was minimal, except for, I would say, moderate for the chaplains after they meet with families, which kind of makes sense because we're asking them to basically generate the content for that report, which is not minimal work. Taking a step back, we learned a lot of lessons from the single-arm feasibility study. We made some changes for the pilot randomized trial that's ongoing now. We revised the patient eligibility criteria further. We refined consent forms in the recruitment pitch on numerous occasions, including most recently, I've been working with a coach to help, and this has really helped our recruitment. And then we're trying to strengthen the intervention. We try to find ways to disseminate the report more widely in the ICU so that it's not only tied to a family meeting. We had one family member tell us in an interview 1 month after the ICU stay that like the family meeting went really well, but she felt that a lot of the informal communication was poor and lacking in empathy and compassion. And so now we're trying to influence that as well. The second the report gets created, we email it to the ICU attending and fellow. We put a hard copy in a binder in the ICU physician workroom. We also have a hard copy in a binder at the nurses station, and we're encouraging the nurses and other providers to read it. And we've added this EHR banner that pops up when a report's in there to try to get people to go to the pink binder to read the report. This is a question that commonly comes up. Why not put it in the EHR? We're doing all these like other things, but our chaplains are hesitant to document the level of the detail that they're putting into these reports. There's sensitive family experiences that would go into patient charts that could later be read by patients who survive. There's sometimes complex family dynamics that are playing out, really complex feelings that are going into these reports. And there's also comments on staff interactions. And our chaplains just don't feel comfortable putting these in the EHR right now. So I'm briefly in a minute or two, we're now in the process of the pilot RCT. Here's the flow. We basically have the enrollment questionnaire, and then we randomize them into 2 groups, and they complete questionnaires at the same time. Our goals, the first 3 are the same, but now we're also looking at the proportion of families we approach to enroll, family acceptability of random assignment, differential dropout by arm, and our ability to collect data per protocol for families in each group. We broadened the patient eligibility criteria to just an acutely life-threatening illness. We just need the patient to be in the ICU for a while now, and still we have lacking decisional capacity because we know this adds a lot of stress to families, and we haven't changed any exclusion criteria. This is actually a little outdated. We've actually enrolled 25 at this point, 15 in the intervention, 10 in the control, but it was a lot of work to go back and update this. Excuse me. But the early fidelity measures have generally held. The most important thing is we've shifted enrollment to earlier in the ICU course, and we've shifted the initial chaplain meetings to earlier in the ICU course. So before it was like a meeting of 4 days, now the first meeting is a meeting of 2.1 days after ICU admission. We have not had anyone drop out in either arm. The survey completion rate has been similar across arms. So coming back to this big picture, it's early days, but I think we're starting to answer some of our questions. It seems like we can implement the intervention with fidelity. It seems feasible and acceptable to participants. We still have a lot to unpack about experience, particularly differential experience among key subgroups. And we're using qualitative data that we've been collecting. The pilot RCTs, going to help us understand about attrition in the usual care arm. But I think even bigger picture, I think we're seeing preliminary evidence that families value an intervention that focuses on meeting their emotional support needs, that chaplains have the skills, the training, the time to spearhead efforts to enhance emotional support for families, and that ICU clinicians value information that chaplains learn about patients and families. And there probably are many opportunities to try to, take chaplains that I think often operate in silos and try to build them into like key members of the ICU team. And so our next steps are to finish the pilot randomized trial, to analyze the qualitative data for richer insights, and hopefully get funded to conduct, the next step trial, which would be to test whether families randomized to their program report that ICU teams better meet their emotional support needs during the ICU experiences compared to usual care, trying to see if we're actually moving the behavioral risk factor. So I think that leaves about 10 minutes for questions, comments, advice. Thank you for your attention. And I would very much appreciate if you could take a few moments either right now or immediately after, provide some feedback. It's totally anonymous. It helps me learn how to be a better presenter. And also, having evaluations just helps with like academic advancement. So thank you so much.
Thank you so much. That was a great presentation of a really amazing body of work, and it's great to see how you're kind of working through the stages of developing an intervention. I see Bruce came on camera, and actually I really wanted our chaplains to give you feedback first, since
Yeah, I love that.
I'll introduce that Rabbi Bruce Pfeffer, who's one of our chaplains and has been an interventionist on our trials too.
Cool.
I wasn't planning on talking. I just
you were just turning on your camera to be friendly.
Yeah, but the word counselor, I guess it does bother me, but I'm getting over it because we're not trained as counselors. Because I've heard that suggestion that be used before, but it doesn't seem to be a problem with your study, so it's okay. But in the back of my mind, I'm a chaplain, and I feel like I get pushed back. I'm a rabbi, and Jews don't like the word chaplain either. And by being a chaplain, they say, oh, I guess it's not like what we thought. And so I'm hoping that we slowly change that way of looking at it. But your point is well taken.
Thanks for that comment.
Any other of our chaplains have any feedback or questions? Reverend Barlow?
Yes, so I'm a chaplain here at University Hospital, and through the presentation, which I greatly appreciate, thank you so much for doing this study and sharing. There was a portion that spoke about the physicians not finding the information in the chart helpful. I'm curious to know what would be helpful information that they would be wanting from a chaplain. What information could we share that would be helpful?
Yeah, that's a great question. I think one of the things that hopefully we're going to be able to learn from the work we're doing is that, and because we're having them sort of circle what's helpful and tell us what's helpful about these reports, is my hope is that once we have a bunch of these reports collected, we'll be able to go back and try to identify the things that are rising to the top of what's helpful, and maybe use that to help guide how chaplains what they put in their notes. But I think that's really important.
Matthew, are you familiar with Paul Galshet? He's a chaplain researcher who's done some work on chaplain notes.
Mm,
He might be someone good to look up.
yeah, I will.
Galchutt, I think, Paul.
Okay, thank you.
But he's done some writing on, and I'm interested in this too, as far as making the notes as valuable for the interdisciplinary team as they can be.
Yeah, I think that's important.
All right, Jay, did you have a question or comment?
The comment was just to say thank you. I'm the leader, Vice President of Spiritual Care for our system, and just found your presentation very interesting. To pick up on Reverend Barlow's point, and I think you covered this in your slides, but just to hear a little bit more about it, did you find that providers needed much encouragement to read chaplain notes? We often find that, or at least anecdotally, that we put notes in there and folks don't often seek them out. When they do, they say, well, boy, that's helpful. Did you look at that part of it and I just missed it?
Well, I mean, that was a worry I had. Initially, we wondered, we thought about putting them in the EHR, and one of the worries I had was that they were just going to get buried and no one was going to read it. And so we decided, actually, we kind of need to like shove these in their face right before a family meeting so that they can, see if there's value to it. And hopefully if we start establishing that, hey, there's actually value in this information, then that might move the needle, and then they may start eventually being, interested in going to seek them out. But that was kind of the approach we took, was like, we got to just get it to them and show them that they're valuable. And I didn't talk about, we've interviewed several clinicians, and I didn't talk about it, but they are finding the notes, these reports, really helpful a lot of times. Learning information they wouldn't have learned. Some of the SARMA are saying it's saving them time in the family meetings and really giving them a leg up when they're walking in. So I think I think chaplains are getting a lot of valuable information, information that clinicians value.
Matthew, I have a kind of a technical question. Does the chaplain attend the family meeting?
It's optional. For the most part, they have not been attending the family meeting. And part of this is just time and logistics, because these are our own hospital chaplains. They have a bunch of other patients they're trying to see. They're already meeting with the families, taking another 30 minutes to write the report. It's been hard for them to, also get to the family meeting. So we have had some attend, but not everyone. And maybe if I get more funding at some point, we could hire some, have some chaplains be more dedicated to this project, and then they have more time to maybe be in the family meeting. But right now it's all, they're just providing their services.
Right. Well, there are pluses and minuses. I mean, it's true that it would be great in some ways, but it might not mirror real clinical practice. And also, in your larger study, if you can record more of these family meetings in both intervention and control groups, it'll be really interesting to see if you've been able to change clinician behavior. Obviously, if the chaplain was there, they would take on a lot of that emotional support. But the question is, are you successful in changing clinician behavior? And so, I think there are pluses and minuses. I'm not promoting it, just asking.
Yeah, no, exactly. I agree. And I think we want it to be as pragmatic as possible and as scalable and within the workflow of an average hospital chaplain.
Right, right. Does anyone else have any other questions? Thank you, Jay.
Hello, my name is Alan Minsley. I'm a chaplain here at IU Methodist Hospital. And just the observation about chaplains attending family meetings, I've just observed, not all the time, but sometimes family members will think that their loved one is actively dying, and that's the only reason why the chaplain is present. So I just wanted to observe, or just put that out there.
Yeah, I think that speaks to these myths and just this misunderstanding that's out there, that It's really hard. Really, we struggle a lot with that.
You know, Matthew, in our study, we have just been talking about documenting usual care and talking about what that is, and the fact that it is usually late and usually around a death. And so, yeah, normalizing a chaplain's role in a different way, I think, is important, but it means that then we have to kind of do it, right?
Yes.
So, all right, Marcos, I think if you have a question, this will be our last question.
Yeah, Matthew, thank you for sharing all of this wonderful information and study. My question might be going kind of the nuance of the ICU experience. Have you found any, and forgive me if you presented it in one of the slides and I missed it, a difference in terms of the efficacy, the receptivity of spiritual care or the counseling, kind of the variability of the mechanism of injury or the reason for admission. So, for instance, it's very different if there is a family who is in the ICU after a trauma, right? Something very sudden, a motor vehicle crash versus a hematology oncology stem cell patient who is having a crisis, and they've been on this roller coaster for, they've had previous stints in the ICU. And so there is a certain level of maybe of benefit that the counseling may have for somebody who is just very sudden in the ICU. My child or my patient, my loved one was fine just yesterday, and now this is very sudden, very unexpected. Anything in the experience of families, given the reason for why they are in the ICU in the first place?
Yeah, I think that's a great question, and I think we haven't really been able to look at that with our numbers so far, but that's definitely something I want to look at if we can do larger studies of this. Anecdotally, we had one patient who had a cardiac arrest and then came in, and that was sort of a very sudden thing. And this family really leaned a lot on the ICU support counselor, and this was one that met more than once. And we interviewed this family member a month later, and she was like, "I love that man, the ICU support counselor." And I think that suddenness that was very emotionally distressing in a way that maybe is different for someone with advanced cancer. At the same time, it's still really hard, advanced cancer, and you're in the ICU, and yes, maybe it's not totally as sudden as a cardiac arrest. It's still really hard, I think, for a lot of people. So I think one of the things is sort of we may need to do some screening to make sure that we are delivering the intervention to people who need it as we proceed. I think that's been one of the challenges, and a lot of critical care interventions have had negative outcomes, and I think some of that is because we're delivering it to people who don't need it. Not everyone is suffering from emotional distress, but yeah, I think definitely the suddenness is a big factor in emotional stress.
Well, thank you so much for your presentation. I've learned a lot.
Thank you so much for having me.
Yeah, really great quality work, and it's really a joy to get to hear you present. So thank you so much, and thanks to everyone who's come.
Thank you. I really appreciate the opportunity. It was great.
All right. Take care. Bye-bye.
Bye-bye.